I'd like to begin by welcoming everyone here to another PUA webinar featuring Dr. Anate Brauer. Dr. Brauer is a good friend, always a helping hand whenever I need anything. A quick text message, an email, a call to Dr. Brauer is always very helpful. Dr. Brauer is a reproductive endocrinologist, a fertility specialist, board certified in RMA of New York. She's one of those doctors that's just good, good bedside manner, great doctor. You know that you can count on her and rely on her. And that's why I think it's really amazing to have you here, Dr. Brauer, to talk about the basics of fertility. So many people are just starting their journey. Some people have no idea where they are in their journey. And to have someone like you, someone who's so approachable and so knowledgeable, I think is a very tremendous asset that we can offer, that PUA can offer all of our listeners here and beyond. So thank you very much for joining us. I'm very excited to have this conversation with you this evening.
Thank you for having me. I'm humbled by your words, and you also are always a helping hand to all my patients. So thank you for everything.
It's good teamwork. Okay,
yeah.
So let's get right into the basics. Let's start. Couple is married for 9 months. 9 months. She's 23. He's 24. No kids. What would you say to such a couple that shows up in your office? Would you, how aggressive would you be? What's the approach? And then we'll take it from there as the couple gets older and still no children. What would your approach be? Again, married 9 months and no pregnancy.
So it's important to note that even in your early 20s, assuming that you're ovulating regularly, which we'll talk about, and usually if you're having regular cycles, you most likely are ovulating regularly. Each month you try to conceive, even at that age, you have about a 20% chance of achieving a pregnancy. By the end of 6 months, you expect for 60 to 80% of those couples to be pregnant, depending on what you look at. By the end of 12 months, you expect for 90% to be pregnant, which is usually when we start recommending treatment and workup. But my view is you're never wrong to be a little bit more proactive on the workup side of things, meaning getting testing done. There's this misconception that just because you walk into a fertility doctor's office, you're automatically going to be thrown into treatment. And maybe depending on who you see, you may be, but if you see the right person, the first step in such a young couple is just doing testing. And there's really nothing wrong with doing testing, right? And the way I look at it is, what does it take to make a baby? You need normal sperm, you need open fallopian tubes and a normal uterus to implant, and normal ovaries with normal numbers of eggs and genetically competent eggs, along with some other preconceptual testing, looking at thyroid and prolactin and preconceptual genetic testing, which I'm sure we'll talk about. So I would start with a workup, and I'm happy to go into more detail on what that is.
That was going to be my next question. What does a workup look like? What tests are we talking about? What examinations are these? Are these intrusive, aggressive workup? Tell us a little bit about how you would guide the couple.
Absolutely. So obviously in a consult, I would take their full history, GYN history, menstrual history, find out how they're timing intercourse, specifically as it relates to timing of the period and ovulation and mikvah, and that I'm sure we'll talk about that as well. So to look at the sperm, we do a semen analysis, and I think you can chime in on that. But basically with a semen analysis, which we do at RMA of New York and most fertility centers do them, we look at 3 things. We look at count, which is how much sperm there is, motility, which is how the tails are moving, and morphology, which is how the heads are shaped. The heads have to be shaped a certain way and the tail moving a certain way in order to penetrate an egg. And it's very important to note that male infertility is, men are half the battle here, right? But it's about 30 to 40% of the time we see that there's some kind of male factor there. So a lot of times I see couples coming to me and they've already been giving medications by their OBGYN, but this whole other part is missing. So I do believe in looking at the sperm up front. For the tubes in the uterus, the fallopian tubes are important because that's where egg and sperm meet. The uterus is important because that's where an embryo implants. And the gold standard test for looking at the tubes in the uterus is something called an HSG, a hysterosalpingogram. It's an X-ray of the tubes in the uterus. It's usually done by a radiologist. They just put in a speculum, put a catheter into the cervix, and infuse the uterus with liquid that actually lights up on X-ray, and you can see the liquid filling up the uterus and coming out of the tubes. Another nice thing, even though this is a diagnostic test, is that the month you have an HSG, I always encourage people to try that month because it does slightly increase your chance of pregnancy. So that looks at the tubes in the uterus. And then that brings me to the ovaries. And with the ovaries, we care about two things: egg quantity, so how many eggs you have, and egg quality, what's the genetics of those eggs. So egg quantity, we call that ovarian reserve. How many eggs do you have left? Women are born with a certain subset of eggs. We lose them over a lifetime. And there's numbers that you can look at to see where you are on that ovarian reserve spectrum. One of those is just a blood test that can be done at any time in the cycle. It's called AMH, anti-Müllerian hormone, which is a hormone that's made by the small resting eggs in the ovary. If you come in and see me for a consult, we run it in-house. I do it that day. I have it either the same day or the next day, which is really nice. And that gives you a good general sense of where you are on that spectrum of how many eggs you have left. Other tests are more cycle dependent. So on day 2 or 3 of a period, we can do an ultrasound, look at the ovaries, count how many little resting eggs are housed in little sacs of fluid called follicles. We also send another hormone on day 2 or 3 of the period called FSH, follicle stimulating hormone. That's a hormone that your brain makes that tells the ovary to grow an egg. That's inversely proportional to how many eggs you have left. So the fewer eggs you have, the harder your brain is working and the higher the FSH. So FSH, ultrasound, and AMH looks at quantity. Semen analysis looks at sperm. HSG, or hysterosalpingogram, looks at the tubes in the uterus. And as far as egg quality, there's really no test for egg quality. Egg quality is mostly linked to genetics of the eggs. It's directly linked to age. And we know from testing hundreds of thousands of embryos through IVF that even in your early 20s, around a quarter of your eggs are chromosomally abnormal. That leads to a chromosomally abnormal embryo that either won't implant or won't miscarry, or an egg that won't be fertilized at all. By the time you're 30, about half are abnormal. By the time you're 40, about 90% are abnormal. So that's why I don't think it's ever wrong to get a workup. At least it's almost always covered by insurance. You get all the knowledge. It doesn't mean you have to, if there's something to act on, you're going to act on it. But usually, if everything is totally normal, I'll just come up with a plan for the patient, how many more months they're going to try to conceive. And if they're not pregnant by X month or X date, come back and we'll talk about treatment. And I think having a plan is very anxiety relieving. So that's usually my recommendation in a young couple.
The HSG is part of that initial workup, or would you hold off on an HSG?
So it's very person dependent, right? I think I offer it to the patients, you know, especially after 9 months. If someone's coming to me after 3 months, which sometimes they do, I say, well, you can hold on that, and in a few months, if you're not, here's the referral, here's where you call to do it. If you're not pregnant, you can do it. But it's not wrong to do it after 9 months. If they want to wait, they can wait. At the year mark, I would do it.
At the year mark. I know certainly a lot of rabbis and a lot of Orthodox couples are concerned with the semen analysis to try to push that off as much as we can. Obviously, at a certain point, it's important to test the sperm. As you said, sometimes it's just gross negligence to not test the sperm, especially if the woman is going to have to undergo test after test after test. And here the male is not even being tested. So we totally agree to that. And the truth is, I mean, I'm not sure we were going to discuss it today, but there's even different methods of procurement, some which are really not, compromising halacha one bit, such as like a postcoital type test. You know, when not the actual PCT, but let's say a vaginal collection where the couple has regular unprotected sex, and then they collect the semen from the female after relations, and then bringing that to the doctor. So very often for an initial semen analysis, I mean, are you okay with such a sample for an initial semen
you
analysis?
lose a lot. I mean, you do lose a lot of volume, and so it's not as accurate as we would like for it to be. But if that's
even for a semen analysis, in other words,
yes,
you're just testing.
because if it's abnormal, we're going to have them repeat it.
Agreed. But what happens if it's normal?
If it's normal, it's normal, but there's just, you run the risk of sample loss and having to repeat it. And as long as you're willing to accept that risk, I don't have a problem with it.
Right. So, right. Okay. So the initial workup, you said it is let's say a blood test, a few blood tests for the female at the right time, the semen analysis, maybe an HSG for the female patient, and
genetics.
And genetic screening. Okay, so can you talk to us a little bit about that?
Yes. So we do an expanded carrier screen, and most places do. An expanded carrier screen is basically looking at recessive disorders. It's a preconceptual screen. Recessive disorders are diseases that, first of all, impact about 80% of us. So things like Tay-Sachs, Canavan, cystic fibrosis, Fragile X, SMA, there's hundreds of them, if not thousands. We test for the high impact diseases, meaning if you're a carrier of one of these diseases, let's say cystic fibrosis, it doesn't impact you or the baby in any way. But if both partners are carriers, the baby has a 1 in 4 chance of having that disease. And if we find that out, then we offer IVF, because with IVF, you can test embryos for that specific disease. Rather than having this testing done during a pregnancy, if let's say you're already pregnant, you go to your OBGYN, they do the testing, you find out you're both carriers. Now you're talking about invasive fetal testing and potential termination depending on how severe the disease is. And so it's always easier to do that up front. And that's part of all of our preconceptual panels and many OBGYNs as well. You don't have to go to a fertility doctor to do it. You can go to your OBGYN and get tested for these diseases.
Great. This afternoon, I was speaking to a woman in Chicago who told me that her doctor had just diagnosed her with PCOS.
Okay.
She wanted to know if I've ever heard of that.
Have you?
I'm a little bit familiar.
Yes.
So how does that patient change your the patient either that comes in telling you from an OBGYN that they have PCOS or that you discover PCOS? How is your treatment and how is your whatever your procedures will be and your perspective on this patient? How would that change knowing that they have PCOS?
So first, it's important to note that PCOS is more of a spectrum of a disorder rather than a pigeonhole disease. So PCOS is very common and it's very easy to be diagnosed with it. You only need 2 of 3 criteria. Irregular cycles, which is what often brings people to the OBGYN to even get diagnosed with it, plus or minus some form of hyperandrogenism, meaning elevated testosterone in the blood, or severely abnormal hair growth or very severe acne, although some criteria don't fit that, but some form of elevated testosterone, whether it's presenting itself clinically or in the bloods, and or PCO looking ovaries on ultrasound, which just means ovaries with a lot of eggs in them, which a lot of young people have. So if you have irregular cycles and I do an ultrasound or I do an AMH and you have a lot of eggs, you have the diagnosis. The question is, how much is it interfering with your ability to conceive? And that links back to regularity of ovulation. So if you have cycles every 30, technically 21 to 35 day cycles, meaning when I say cycle, I mean period to period, is considered normal. So let's say you have 40-day cycles or cycles 50 days apart. That gives you maybe, instead of 12 opportunities in a year to achieve a pregnancy, 10 opportunities in a year to achieve a pregnancy. So you might give yourself a little bit longer versus someone who never gets a period or gets a period once every 6 months. That's when we might intervene with medications such as oral medications like something called letrozole or Femara to try to get the brain. And I can explain why this happens in PCOS, but we give you a medication to try to get the brain to get the signal to start growing an egg and making those cycles more efficient and timing that with intercourse. In those cases, I would hold on. If we know that you're not conceiving because you haven't ovulated, you can hold on the HSG. You could technically also hold on the semen analysis, although if after 3 ovulatory cycles, I tend to do semen analysis sooner rather than later. because again, it's half the picture, and I don't want to keep giving someone medication if we don't know if that's okay. But we know that you're not conceiving because you're not ovulating. I'm a little more flexible there, but the HSG you can hold on.
You mentioned letrozole, so I'm
Yeah.
sure many people on this call, on this webinar, have heard letrozole. They've heard Clomid. What is the difference between letrozole and Clomid?
Yes.
How come some doctors prescribe letrozole and others Clomid? What's the difference?
Absolutely. Okay. So to understand that, you should understand just how PCOS works. So in a regular cycle, you start off with a bunch of little resting eggs. They're housed in follicles, and your brain makes a hormone, FSH, follicle stimulating hormone, which does exactly what it says it does, stimulates one of those follicles to grow. As it grows, it makes estrogen. As it makes estrogen, that estrogen tells the brain to stop making FSH because I have my egg for the month, so kills off the rest of them. Then it tells the brain to make another hormone called LH, which is the surge that happens in the middle of the month that leads to final steps of egg maturation and eventual ovulation. What happens in PCOS is in our bodies, we make estrogen by converting it from testosterone. That's how we make estrogen. And the enzyme that converts testosterone to estrogen is called aromatase, and it lives in two cell types. It lives in the granulosa cells, which are the little cells that surround resting eggs, and it lives in fat cells. So, and we know that women with PCOS are more likely to be a little bit higher on the BMI end of things. So if you have a little bit of a higher BMI, and you have a lot of little resting eggs with a lot of little granulosa cells, and you have a little bit of extra testosterone, and it goes to those cells and it gets converted by aromatase to estrogen, now your brain sees the estrogen and it thinks, oh, I have an egg growing. I don't need to grow an egg. And remember, estrogen provides negative feedback. It tells the brain not to grow an egg. And so the brain never gets the signal. So letrozole, or Femara, is an aromatase inhibitor. It inhibits conversion of testosterone to estrogen. And that has become the mainstay of treatment for ovulation disorders as it relates to PCOS. Clomid works a little bit differently. Clomid masks the brain from seeing estrogen on a central level. So it blocks receptors in the hypothalamus. And so the brain doesn't see the estrogen. So it doesn't block the conversion. It just doesn't see the estrogen. And we're more likely to use Clomid in patients with unexplained infertility. And these drugs were compared head to head by a guy named Legros, who did a lot of work at the NIH with PCOS. And in 2013, and before this paper, he published also about metformin alone, metformin with Clomid alone, and showed that Clomid was better than metformin. Then he compared letrozole to Clomid head to head, and that was published in 2013, and showed that in specifically a PCOS population, letrozole had better efficacy as far as pregnancy rates, as far as monofollicular ovulation. We just want to ovulate one egg. We don't want twins. I know everyone loves twins, but we don't. Versus Clomid had lower pregnancy rates. You're more likely to ovulate more than one egg, which we actually want in cases of unexplained infertility, because with unexplained infertility, we don't know what's happening. So we're trying to increase the chances of pregnancy by allowing more than one egg to ovulate. So in PCOS, the mainstay of treatment should be letrozole. If the initial dose of letrozole, sometimes ovaries are very resistant to these medications, especially ovaries with a ton of eggs in them. We start with a conservative dose. If it doesn't work, we step it up to a higher dose. If it doesn't work, we'll switch to Clomid. If none of that works, we can talk about what we would do. But I always start with letrozole. And you'll see that most board-certified fertility doctors will start with letrozole because they're aware of the data.
So how many cycles with letrozole would you have a patient complete before moving them over to Clomid? And then how many months on Clomid before considering the next step, whether it's an IUI
if
or something?
If letrozole works for ovulation, I would not switch over to Clomid because it's not offering you much benefit.
In other words, so the patient starts taking letrozole, and with ovulation checks, we find that, in fact, that the patient is ovulating. Right. However, there's no pregnancy. So how long would you keep a patient on letrozole for?
So I would say 6 cycles. By the end of 6 cycles, about 80% of patients should be pregnant. And then we have a check-in, and I usually have a check-in after every 3 cycles because most of these patients are anxious to conceive already, right? And so every 3 cycles, I'll have a check-in. Okay, do we want to continue with timed intercourse, or do you want to add an IUI, like an insemination, which may bump it up a little bit? But after 6 cycles of oral medication, we definitely have a follow-up to talk about, do we want to continue this path, or do you want to get more aggressive, which is usually IVF at that point. I don't really believe in injectable IUIs. I think that's really a thing of the past. It's not really increasing your pregnancy rate. It's only increasing your multiple pregnancy rate. And so we have at least a discussion about IVF. And what I love about what I do is there's no right or wrong. It's just giving people options, talking about the pros and the cons, and coming to decision together. It's not like, you have diabetes, you have to take this medication. These are the options, and you decide. You're the captain of the ship on how aggressive you want to be.
And if the patient really doesn't want to do an IUI, they do not want to do an IVF, they really want to continue this.
Fine.
So you said 6 cycles on letrozole, unfortunately, nothing doing. So then would you recommend switching over to Clomid?
If they're ovulating, and because the whole point is just to get them to ovulate. And if you think about it, women without PCOS are ovulating every month for 12 months. And that's the cutoff of moving into treatment. So if they're ovulating on letrozole, letrozole also has a lower side effect profile. It's just better tolerated in general. So
you let them go on for the year.
I would, if that's what they want. I don't think there's any benefit in switching to Clomid. Now, once you hit a year, now you're an unexplained infertility patient, right? Because you've been ovulating every month, because the definition of unexplained infertility, normal sperm, open tubes, normal uterus, ovulating every month for 12 months. Now you're unexplained. Okay, so maybe then you would want to use Clomid to try to get the benefit of growing more than one egg. But maybe it's because I practice on the Upper East Side of New York, but none of my patients are waiting a year on oral medication. I feel like, yeah.
Totally understand. So let's shift the discussion to a different patient, not a PCOS patient, but a patient that presents with painful periods. You suspect there's endometriosis. They don't have a diagnosis. It's really the first time that they're seeing anyone about it. How would you kind of explain it to the patient? What's happening? What's going on? How would you diagnose endometriosis, and how do you treat it?
So endometriosis is an interesting disease because it masquerades as a lot of different things. There's a huge gap between onset of symptoms to diagnosis. And burden of disease does not always equate with symptoms, meaning you can have very mild disease and have terrible symptoms, or have terrible or the opposite. And the only way to actually diagnose, the gold standard for diagnosis of endometriosis is a laparoscopy, meaning you put a scope in the belly button and you look around and you either see it visually, or you take a little piece and send it off to pathology. And if I were to scope 100 women walking around on the street, I would find endo in probably over 50% of them that are totally unimpacted by it. And so the question becomes, to me, there's a delineation between someone who has endometriosis and is not trying to conceive, and you're talking about pain control and symptoms, et cetera, versus someone who has endometriosis and is trying to conceive. In my patients who I suspect endo in and they're trying to conceive, the biggest concern for me with endo is the tubes, right? Because endometriosis causes inflammation in the pelvis. It can cause scar tissue, which can block the tubes. So I want to make sure in those patients, I would do an HCG on the earlier end of things to make sure the uterus is fine and that the tubes are open. And then I would move into treatment, because ultimately the most efficient route to pregnancy with endometriosis is not necessarily having a surgery for the endometriosis. It's probably IVF, because another reason it is IVF because of the inflammation, you have much lower fertilization rates and implantation rates. And so if that fertilization occurs outside of that inflamed environment, that's the whole idea behind why is IVF a more efficient way to conceive for endometriosis. I'm not saying you should go straight to IVF, okay, by no means, especially in a young person. But that's what I personally would not, whereas we used to recommend a scope up front, unless you're having very severe pain. If you're having very severe pain, that's interfering with your life, then I would send you for a scope because, I want to treat your pain. But if it's, cramping and it's tolerable and you're really just trying to conceive, what we need to be focusing on is getting you pregnant as soon as possible, because once you're pregnant, that also kind of subsides the endo. So that would be I would just do the HSG a little bit earlier in a patient like that.
Okay. And what happens if the HSG shows us that that there is in fact something blocking the tubes? So then what?
If both tubes are blocked, I would go straight to IVF.
And if only one tube?
If only one tube is blocked, technically speaking, having one blocked tube does not change your pregnancy rate. And that's been studied in patients with a history of self-injectomies for ectopic pregnancies. So someone that's had their tube removed because of an ectopic, technically that should not change the pregnancy rate. So I would treat them very similarly, but if both tubes are blocked, I would you have to move on to IVF, because all of the tubal cannulations and all of those things have a very low success rate. It also puts you at an increased risk of an ectopic pregnancy. If there's one tube blocked, a lot of what we do is kind of a conglomeration of factors. So if there's one tube blocked and the sperm is maybe a borderline and the AMH is a little borderline and you want 4 or 5 children, that one tube blocked might kind of put us over the edge to being more aggressive sooner rather than later. But in and of itself, if everything else is totally normal, it wouldn't totally change my management.
Yeah. I remember the first time I was trying to wrap my brain around that, wait a minute, you mean that eliminating one tube doesn't knock your chances of pregnancy down 50%, shouldn't it? Yes. Especially if you're ovulating from every other tube every other month.
But there's no proof that the egg that ovulates from the right side goes to the right tube and the egg in the opposite, right? Because when you ovulate, the egg is just, that little follicle bursts and the egg just goes floating into the abyss of the pelvis and then gets picked up by one of the fingers at the end of the tubes. And it's amazing that any of us are here. All these people say to me, like, you're such a scientist. Like, how do you believe in God? And I say, how do you not? Because it's really unbelievable that all of these things happen at the same time. So we have no proof that one goes to one side and one goes to the other.
Right. Okay. So, hold on a second. There are some questions coming in.
Sure.
Okay, we're definitely, so this is the next topic that I was going to discuss, and someone just mentioned it, and she writes, halachic infertility. We don't like to call it halachic infertility because I don't want to give off that message that keeping halacha will
so
cause
negative. No.
Yeah, so we like to call it early ovulation.
Yes.
Early ovulation, and the truth is, I was speaking as I was driving to my office today for this very webinar. I was talking to a young woman, married 6 months. She's 32 years old, and she's very nervous about pregnancy. So she told me before she got married, she did a workup, and she seems that everything seems to be okay. But she did notice that she ovulates on her LH surge is either on day 10 or day 11. So I guess she's using sticks, ovulation sticks, and the ovulation sticks are showing her that she's having this LH surge, which again, you mentioned briefly, but if you want to discuss it in greater detail, you may. And she wanted to know what should her approach be. She's on her 2nd or 3rd day of her period. So she was asking me in terms of from Nida and mikvah, how can she get to the mikvah earlier if necessary? So I guess from your perspective, I mean, it happens to be that you're a Jewish doctor. It happens to be that you are familiar with Nida and mikvah and that. But talk to us about like any other doctor that's not you, right? Non-Jewish doctor dealing with an Orthodox Jewish patient. Are they aware of the mikvah cycle? Are they aware of the fact that this couple won't have intimacy until like day 12 of their cycle? And how should the Orthodox patient kind of speak to their doctor about that, or balancing the fact that they have a mikvah calendar that they're trying to sync with their ovulation, and if they can't, so what do you do from your perspective as a physician?
So one thing I want to mention that's overarching as an aside about women who ovulate earlier. That's very important, because the reason that, if you're someone who used to have 30-day cycles and now you have 28, 26, 24-day cycles, meaning from period to period, you're ovulating, you used to ovulate on day 14, now it's day 10, 12, etc. As we get older and we lose ovarian reserve, our brain works harder to grow an egg, and it works so hard to grow an egg that it starts working on growing an egg in the second half of the cycle before you get a period. So in the luteal phase, so after ovulation of the last cycle, it's already starting to work on it. So it shrinks the first half of the cycle, therefore shrinking the overall cycle. And that's important, because if you're someone who ovulates very early, you really want to get your ovarian reserve tested, your AMH tested, to see where you are on that ovarian reserve spectrum, because most likely, in most cases, it's a little bit borderline or even low. And if you're someone who wants multiple children, you may want to talk about things like fertility preservation and other things for the future. So that's one aside, because to me, I'm always much more concerned about women who ovulate early than women who ovulate late. Because women who ovulate late, who are on that PCOS spectrum, I know they have a ton of eggs, and eventually we're going to get a pregnancy. I'm not worried about that. But the early ovulation concerns me from an ovarian reserve perspective. So that's number one. That aside, if you're seeing a physician and this is something that's inherent in your medical history, you should I'm always a fan of patients advocating for themselves we hear everything under the sun, bring it up and say, do you know what this is? And if the answer is no, maybe that's not the right, physician for you. I'm going to be very honest. I think in most practices now, especially on the East Coast, you have to be familiar with it. And that's why we bring wonderful people like you to come in and explain it and talk about it. And as far as treatments, so some physicians go with Clomid, which can sometimes delay ovulation, or you can use estrogen patching, which to try to delay ovulation. We do that a lot with IVF as well. Once if you end up in an IVF category, it's much easier to control, because that's a whole other, now we're talking about frozen embryo transfers, and you can control anything with that. But really, Clomid and or estrogen patching is the mainstay of delaying cycles.
Yeah, we've had a number of cases where even that didn't work. And
you can also use a birth control pill
the birth control, but then we ended up doing an IUI while she's before the mikvah. Before the mikvah, we had either frozen sperm, or we were able to get the sperm, and then there's no physical contact between husband and wife until they go to the mikvah. But we had a woman, she ovulated on day 9, and there was no estrogen and no Clomid, nothing that she could take was pushing it off. And so we had to do a series of IUIs, and Baruch Hashem, she had a baby. But the early ovulation, together with, this is why it's so important to have not just the physician who knows what you're talking about, but even Rabbanim who are familiar with the situation and how to help the situation. I think that that relationship where the doctor is doing everything on their end and the rabbi is doing everything on his end to make sure that you're not going to the mikvah a day late, and bedika cloths are being checked and no one's being overly machmir, and you're getting every single halachic leniency in the book. So really, with that teamwork, kind of this triangle, we have doctor, rabbi, and patient. A lot of cases of early ovulation can be solved. So that's a good thing. That's really, thank God, very helpful. Dr. Brauer, there was someone who sent in the chat just to follow up on AMH, what you mentioned earlier. She wrote, I was just at a fertility specialist today, and I have low AMH levels. Curious to hear any advice. So I don't know if this patient is single or this patient is married. I don't know what the AMH levels are specifically, but do you have any general advice on so many women that get this test and are told that they have a low AMH?
So getting your AMH checked is a double-edged sword.
Well, hold on just one second. I'm sorry, because she just responded. She's married, age
0.6, 27. I see. 0.6.
Yeah, she's age 27, okay. 0.6.
Yeah. So the thing about AMH is that, first of all, there's a lot of inter and intra variability to the assay. So you can send it on the same person on the same day to 2 different labs. It's going to be a little bit different. And you can send it to 2 different, a week apart, it's going to be a little bit different. So first, women who have it checked, and then they have it checked a few months later and say, oh, it went from, 1.5 to 1, it dropped. No, it didn't drop. It was probably just the assay. Okay, that's number one. It's not a perfect test. Second is, all AMH tells me, what I use it for is, if I'm going to give you medications to grow eggs, to either freeze them or make embryos from them, how many am I going to get? It doesn't tell me anything about the quality. It doesn't tell me anything about natural conception at all. There's women walking around out there with low AMHs that have no idea they even have them because they've had 4 or 5 kids. They never went to a fertility doctor. This is something that for me is very personal, because when I was a fellow, I was 33 years old and this new test came out, and my senior fellow at the time said, oh, you should test yourself. And it was very low. It was 0.58 at 33, and it threw me into a tizzy. I've wasted my life. What am I doing? I've been married since 30. I haven't even, and I ended up doing IVF for my first child and never tested it again. And then got pregnant 2 years later with the second one, and 3 years after that with the third. And so it doesn't dictate, it doesn't dictate anything about your ability to spontaneously conceive. So that should be very reassuring to you, because you're young and you're probably going to need no help at all. But when you want a big family, it's a huge stressor, because let's say you need IVF for the second baby or the third baby or later on. And while it doesn't dictate success in nature, it does dictate success in an IVF lab, because IVF is a numbers game, and it's all about the more eggs you have, the more embryos you have, the more likely you are to be successful. And so not that it's medically required for a low AMH to jump into treatment, but it may be reassuring if you want a big family to at least have a conversation of fertility preservation for the future, whether it's through eggs or embryos. But it doesn't dictate chance of conception in nature. Like if you're struggling to conceive, this is not the reason why you're not conceiving. But it may change your management.
Nice. We received a few questions in the chat, which was also listed on the flyer, and that is a little bit about male infertility. So let's touch on it. And I kind of really the most fundamental question that I want to ask you is, what is a standard REI, reproductive endocrinologist, comfortable dealing with in-house, and at what point do you refer out to a urologist? So, for instance, we have a young man with a varicocele, and the question that came in was his wife had a few miscarriages, and after the multiple miscarriages, he did a semen analysis and discovered that there was a varicocele. So, is that something that would be dealt with in your office at RMA? Is that something that goes to Dr. Barchama, the urology department? What do you take and what do you send to urology?
So I'm very lucky because RMA has Dr. Barchama, and he's down the hall from me, and we talk every single day about Israel, about everything.
Yeah,
so about
he loves Dr. Barchama. Anyone who wants to know Dr. Natan Barchama, who's the head, I think head of urology in RMA of New York.
He's our one and only.
Yeah.
So
he's a real friend of the Jewish people. He loves Israel. He loves Achenu B'nai Israel, and he's a very, very special person.
The best. So I usually refer to him really for anything. But one point about varicoceles are a little controversial. We don't generally, not just me, but urologists don't generally recommend repair unless they're causing, again, symptoms. It's similar to endo, actually. If you're having severe pain or symptoms from a varicocele, then have it repaired. But short of that, usually people would not recommend, reproductive urologists wouldn't recommend repairing. If the sperm is so severe that it requires a varicocele repair, it takes several months for sperm to bounce back after repair. So they usually would recommend IVF if the sperm sample is so severe, while you're contemplating repair and, more for down the line. But a varicocele repair would happen with a urologist. So for me, if there's the initial semen analysis is low, I send for a repeat. I never send just based on one. You can't glean anything from one sample. I do a repeat 2 weeks apart. If it's still low, I will send to a urologist. Before I had access to Dr. Barchama down the hall, I would send the initial workup. So basic hormones, if it's very low, I would send, karyotypes, so looking at chromosomes and the Y microdeletions, which can also lead to this in like azoospermic cases. And then just get the workup started to send them off to urology. But now that I have Dr. Brahama, I just send directly to him.
Yeah, you're lucky. Great. So, okay, so let's go back to the female patient. So we spoke about early ovulation, something to be aware of, something to be something to constantly consider. By the way, do you recommend, and at what point, testing ovulation with sticks? Are there certain ovulation sticks which are better than others? Like these are at home tricks that we can do, and at what point,
Yeah, I call them the insanity sticks. By the way, if you have PCOS, they're not going to work, because one thing we see in PCOS patients is that LHs are always kind of tonically high. They're always hanging in the teens or low 20s. So the kits are always positive or always negative. And so I say buy the cheapest possible, the least fancy kit, like CVS brand, Walgreens brand, Amazon. And you don't have to check it every month. I would spend 3 months checking it. And if you see that every month you're, ovulating on day 14, 15, that's probably around when you're ovulating. And I would time intercourse around that. And at the end of the day, sperm lives in the uterus for up to 3 days. And so you don't have to have the exact timing. I'd rather have people, if it's okay with where you are in your cycle and mikvah, to err on the earlier side of things so that the sperm is kind of there, waiting. So, if you're ovulating on cycle day 17, I would start trying on day 14, 15, every other day for 5 days. And then you've kind of covered it at that point. So, that's where I think kits are helpful. If you find the kits are driving you crazy, you can always go to an REI and we can monitor you with ultrasound and blood work for a month or two, just to tell you like this is, and if you're having pretty regular cycles, that's probably accurate most months. And then you can throw all the sticks away. But any stick is fine.
So we have early ovulation, checking the ovulation, or even identifying ovulation, which again you mentioned before, but just to bring out because it's so important. Just identifying an ovulation is so critical to your journey and is so important to your treatment plan. What does that look like? Well, do you ovulate or do you not ovulate? It's going to make a huge difference. We spoke about PCOS with PCOS patients that are ovulating more than less, getting more periods or fewer periods. We spoke about endometriosis. Take all those patients. Sorry, I don't want to. You want to say something?
I was going to make one comment about endo, but go
okay,
ahead.
Please do.
Not in a trying to conceive population, but one patient population that's I feel overlooked is the young endometriosis population. If you're someone that has severe endometriosis, who's had surgeries for it, very severe pain followed for it, I would very seriously consider seeing a fertility doctor sooner rather than later to talk about fertility preservation, such as egg freezing, because these women are much more likely to have a lower reserve, especially because endometriosis is first inflammatory to the architecture of the ovary, so it can damage healthy ovarian tissue. And also, if you do have repetitive surgeries, endometriosis is very sticky. So anytime someone's going in and removing an endometrioma, which is a cyst made of endometriosis, you're taking healthy tissue with it and you're dropping those reserves. And so just something to consider. There's times when you should see someone sooner rather than later. Those times are suspecting severe endo or known severe endo and not ovulating, of course, with PCOS. But go ahead. Sorry.
So, very important. So taking all of those patients, whether it's the early ovulation patients, the PCOS patients, the endometriosis patients, the ones who are not yet even at your IUIs or your definitely not your IVFs, and they want to avoid that if they can, of course. What lifestyle advice would you give them to try to not fix all of their issues magically overnight, but to put them in the best, kind of empower them to put them in the best place to be as successful as they can?
Absolutely. So first, I would definitely take a prenatal vitamin. And you really want to have that on board within 3 months of trying to conceive. And the reason for that is you don't even have to take a prenatal. Folic acid is really what we care about to avoid neural tube defects or defects with the spine. So prenatal vitamin, Vitamin D, especially in the winter and the fall, we're all deficient in it. So I would take 2,000 units of vitamin D or go get it checked with your PCP. And if it's even lower, you may need even more vitamin D. Of course, getting all the preconceptual testing that we talked about, the thyroid, the genetics, and lifestyle-wise, BMI is a very important factor. So weight is important. We know that women with higher BMIs are less likely to ovulate. We know that they're more likely to miscarry, more likely to have preterm deliveries, et cetera. And there's so much noise out there with supplements and diets and all of these things, but really we should all be I don't believe in cutting things out. So I would lean towards, we're all trying to lean towards a Mediterranean diet, but really a balanced diet with plants and incorporating omega-3s with lean meats and fish, et cetera. Managing BMI, staying active, avoiding at all costs. I have very few no-nos. You can have a glass of wine here or there, you can have a cup of coffee a day, but smoking, any kind of drug use is an absolute no. That's my only absolute no. And that's what I would tell people is stay active, have a balanced diet, take a prenatal vitamin, take vitamin D. You also hear a lot about CoQ10 out there. I more talk to my IVF patients about that. CoQ10 is an enzyme that's involved in the powerhouse of every cell in the body. It's really good for your cardiovascular health. If you have any cardiovascular history in the family, you should take it. Also good for sperm. There's a couple of mouse studies that it impacts egg quality. I don't totally buy them. We have not seen that in humans, but my older patients or my patients already pursuing IVF, I have them take that as well.
Do you have a lot of patients with higher BMIs who are interested in the Ozempic
Yes.
track? And what do you see, when we compare Ozempic to spontaneous pregnancies?
So I'm not aware, I don't know, about that data, except for that if you are overweight and you have PCOS, if you lose 10% of your body fat, you're much more likely to ovulate. And so we've
Right.
definitely seen in these cases, specifically with PCOS and the help of these new drugs, dropping the weight has resumed ovulation. It decreases insulin resistance, which is also impactful in the pathophysiology of PCOS. It's important to note, however, that you cannot be on these drugs during pregnancy. If you are planning an IVF cycle, you should stop them at least 2 weeks before, and because of anesthesia risk. And so these drugs have been really a game changer for a lot of my patients, but there are, you want to kind of be done with your weight loss journey before starting to try to conceive.
Mm-hmm. And what impact does stress play on the fertility journey, which is obviously a double-edged sword because it's such a stressful journey, and it's even
Yes.
more stressful to tell someone not to be stressed out because
Correct.
stress causes infertility. So, like, how do
Yeah.
you deal with that?
So life is a stressful state, right? And when you look at very stressful time periods in history, so the Irish potato famine, 9/11, COVID was a little bit different because people were afraid to try to conceive because we didn't know enough about it. But in those other times in history, fertility rates didn't really go down, even in very severely stressful states. And so it's important to try to mitigate stress as much as you can. Through activity, through acupuncture, through whatever you see fit, yoga, meditation, etc. But even very stressed out people get pregnant. And so that is not the end all be all of why you're not conceiving. Of course, there's physical stress like anorexia and professional athletes who that's a different kind of not ovulating than PCOS. That's called hypothalamic amenorrhea. And that's when your brain isn't making the FSH and the LH to tell the ovaries to grow any eggs because your brain is saying it's not a good time for me to get pregnant because my body is very stressed out because I'm not eating enough or I'm running all the time. It's a little bit different than mental stress. And that you definitely have to mitigate, but life is stressful and you try to mitigate it as much as you can. And I think having a plan with in a good care team is really helpful to mitigate that as much as possible.
You mentioned acupuncture just now. I mean, is that something that you offer your patients? Is that something you recommend? Do you find it more successful in PCOS patients?
So acupuncture is interesting. If you look at studies look at randomized controlled trials, there hasn't been a huge difference specifically with things like IVF, et cetera. Although my acupuncture colleagues, who I love dearly, would argue against that because their studies show that it does. So, but my view on acupuncture is if you find it relaxing, which a lot of patients do, over 70% of my patients are doing acupuncture and they find that it helps them feel more control over what they're doing. They're kind of feeling like I'm doing everything I can for this. It gives you 30 minutes to an hour of being away from the world, which is very hard to do these days, right? Away from your phone, away from the busy streets, kind of you time. And for a lot of patients, it's really very relaxing, which I think is stress mitigating. If you find it more stressful, like because you don't like needles or it's another appointment or it's more money, then it's counterproductive. That's my view on acupuncture, but most of my patients do really like it and enjoy it. We don't offer it in the clinic, but I do work with several acupuncturists who are excellent.
And have you found that it's specifically in PCOS patients or patients who are presenting with abnormal or irregular bleeding? Does the acupuncture actually help bring
I
back
mean,
some
I'm a little
regularity?
biased. It's a bias, right? Because most of those patients are seeing me in conjunction and I'm treating them. And so
Right.
I'm not, you'd have to not do any of this and just, randomize just to the acupuncture, which most of these patients are doing some other adjunctive treatment, whether they're losing weight or they're, taking medications with us, et cetera.
Right. Right. Okay, there's one follow-up question, and then we're going to
Yes.
go to closing remarks. Just
Okay.
back to the Clomid and Letrozole
Yes.
topic because I think it's so relevant for everyone. I loved how you explained the difference between Letrozole and Clomid and how Letrozole would be more specifically or more a more appropriate fit for the PCO patient as opposed to the unexplained infertility patient. Would you recommend trying Letrozole for a few months for unexplained infertility before going through all the testing?
Not usually. Because again, letrozole is more likely to lead to monofollicular ovulation, and women with unexplained infertility are already ovulating one egg in a month.
Mhm.
So there's not much of a side effect profile, and I think a lot of general OBGYNs feel comfortable giving it. But why take a medication when it's not really moving the needle? And specifically with unexplained infertility. So once you've been trying to conceive for 12 months and you've checked everything and you're not successful and everything's normal, your pregnancy rate per month drops to about 3% per month. Adding just Clomid or Letrozole to that with timed intercourse is bringing it up to 5 or 6% per month. Pairing it with an IUI brings it up to about 12 to 15% per month, back up to where you should be in nature. If you're doing Clomid, I would not recommend doing Clomid with timed intercourse. I have some patients who come to me with unexplained infertility and they say, I want to do something, but I don't want to do an IUI. So usually with unexplained fertility, I would say use Clomid, except for that one of the side effects of Clomid is to thicken the cervical mucus, which is why I always recommend pairing that with an IUI because you're bypassing the cervical mucus. If that patient says to me, yeah, I want to do something, but I don't want to do an IUI, I say, okay, if you want to do timed intercourse, then do letrozole. Even though I know it's not moving the needle a lot, they're the captain of the ship. So that's what I would, that's when I would do letrozole with timed intercourse for unexplained infertility if they decline an IUI.
Makes a lot of sense. I was going to ask you for a closing remark, but then someone asked, "Can you explain the concept of IUI?" And I feel for this webinar, which is all about understanding the basics and understanding first steps, and we did mention IUI so often. So can you just take 2 minutes, explain what an IUI is, when is it most appropriate, when is it unnecessary, when you think it's perfect for that patient, and then unfortunately we'll have to call it a night. But it seems like from the amount of people that are here and the questions that are coming in, Dr. Brauer, I think that they're going to want a part two. Just saying.
Sure. No worries. I'm down for it. So IUI stands for intrauterine insemination, which basically means we take the sperm, we concentrate the sperm to have the most motile sperm, draw it up into a catheter, put a speculum in, pass it through the cervix, and place the sperm in the uterus. The sperm still has to do all the rest of the work. It still has to go, swim to the tube and find the egg and fertilize it. So you're just putting it a little bit closer to where it needs to be. And we generally pair it with medication like Clomid or Letrozole in some cases. And we mostly use it for unexplained infertility. to bypass any kind of cervical factors or, losing volume factors or, unexplained fertility. We don't know what the issue is. There's only so many weapons in our arsenal that we can look at with timed intercourse or an IUI versus IVF. A lot of people will walk into an IVF lab with unexplained infertility and they'll walk out with an explanation because you're looking at the eggs with a microscope or you're looking at the sperm and you're looking at the fertilization rates and the embryo quality, et cetera. But IUI, we're kind of doing everything we can to take out any factors. So putting the sperm a little bit closer to where it needs to be and concentrating the most motile sperm.
And for a male patient that has, perfect sperm, A++ sperm, does an IUI contribute much to the potential success?
Only cases of true unexplained infertility, meaning trying for 12 months and not successful.
Mm-hmm. Great. Okay, Dr. Brauer, this has been exceptionally informative, educational, and inspiring. If there's any last remarks you'd like to share with our listeners here tonight, please go for it.
We need more Jewish babies, so don't wait.
That's it.
Anyway, that's the final remark.
I hear you. I couldn't have said it better myself. Anyway, Dr. Brauer from RMA of New York, thank you so much for joining us. If anyone wants to get in touch with us, you have our information, the email that went out. Email me. I can easily put you in touch with the RMA team of amazing staff. And we're here to help. PUA is here to help. RMA is here to help. As Dr. Brauer said so eloquently, we need more Jewish babies. So we wish everyone bracha and hatzlacha in all of your endeavors, your journey, wherever that may be. And please feel free to be in touch. Wishing everyone a great night. Thank you, Dr. Brauer. And thank you, everyone.
Thank you so much. Thanks, everyone. Bye.
Bye-bye.